Remind each of you that there are instructions in the chat area. So again, hi, welcome everyone. Welcome to Dental CE Academy. I'm Dr. Kirsten Kroling, and this evening's program is Treating the Pregnant Dental Patient. This is for 1 continuing education credit, and we are recording this. So if you are watching the recording right now, it was recorded on November 9th of 2023. My conflict of interest and financial disclosure. This course was supported this evening by Perio Protect. I've not received an honorarium, and I declare no financial affiliation with Perio Protect. No corporate entity has influenced or contributed to the content of this presentation. I am the Chief Education Officer here and an employee of Dental CE Academy. This is our agenda, 5 to 6. I am presenting a 1-hour CE credit, a course followed by a presentation by Dr. Tanya Dunlap, the Vice President at Perio Protect, and she's going to talk to you about treating pregnant patients as well, but how to include Perio Protect's treatment plan with that treatment. So please stay on. It is not required for CE credit. I have to disclose that, but we hope you'll honor their sponsorship and stay on with us because it's tremendous information. She's going to present several cases to you. They're very interesting. I had the opportunity to take a look at those today. To obtain CE credit, you must successfully complete a brief quiz by November 16th. That's in 7 days. You'll need 80% passing score. You have unlimited attempts, and again, 7 days to complete. At any time today, if you have any questions or comments, please type them into the chat area. I'm happy to address your questions. At 6:35 this evening, Pacific time, all attendees will be sent a reminder email to complete the quiz for CE credit. I ask that you do not start sending emails at 6 o'clock because it's going to jam up my email and we're not going to be able to respond to all of you. So hang on till 6:35. When we do log out, anybody who is in attendance will also be redirected to the quiz. Learning objectives are in your handout. And again, I do want to emphasize for those of you watching the live information this evening, please go to the chat area. You'll see an orange box. Go to where it says download the handouts, agenda and instructions, and tap on that link and you can access the handout. It was also emailed to all attendees about 30 minutes ago. For those of you watching the recording, you can drop below the video player. You are going to see the instructions section. Tap on number 3 to access the quiz. Tap on number 2 to download the handouts. All right, so we are talking again about treating the pregnant patient. A little background about me. I'm a public health dentist. I was the chief for the Office of Oral Health for Maricopa County's Public Health Department here. And I was tasked with developing a maternal health program here for the county. I'm in Phoenix, Scottsdale area right now. And that turned out to be one of the largest maternal oral health programs in the country. So I'll be sharing some of that information with you this evening. So the World Health Organization tells us that oral health is closely related to overall health and to the quality of life. And significance of oral health in healthy pregnancies. We know that oral health is important across all lifespans, especially during pregnancy, because we have 2 patients, right? We're treating 2 patients actually. So all treatment that we consider must be beneficial to the mother while minimizing risk to both the mother and the fetus. And oral disease, we know, has been implicated in adverse pregnancy outcomes. And oral disease in the mother can lead to early childhood caries in the child. And managing oral disease during pregnancy is vital, again, to both mother and child. And there are multifactorial barriers that exist that prevent or delay treatment for pregnant women. Often, pregnant women may not seek or they may not be advised to seek dental care as part of their prenatal care. There are limitations that inhibit providing oral care to pregnant women. And there is sometimes just a misunderstanding or lack of knowledge that creates a significant impact on the quality of life and safety. And I can tell you that I've practiced in at least 20 different public health departments over my career, and in in-house services. And every clinic I was in had a different policy that they created to treat pregnant women. And most of those policies were not based on science. Somebody decided that it was going to be dangerous to treat a pregnant woman who came into the practice perhaps with some sort of infection, where they did very minimal care, and they missed a real opportunity to provide comprehensive care as well and prevent that patient from having problems down the road, and also their unborn child. So again, all of these different clinics had different policies. And so what I hope today is distill some of that information down for you so that you can make an educated decision about your own practice or clinic. Now, many dentists routinely deny or delay treatment because they're concerns of litigation. And we know now that the litigation we also need to be concerned about is lack of treatment, right? Not treating a pregnant patient that could lead to an adverse pregnancy or adverse pregnancy outcome. Many prenatal providers may not have been trained in the oral systemic connection. I think that we see with our medical teams now, obstetric teams, they're pretty hip on oral care, but does that get messaged to the patient necessarily? And it depends on the population that we're treating. The population that I was treating, they weren't getting the message, right? And that has to do with many factors. But ultimately, there is a coordination that's required between medical and dental providers to benefit maternal and child oral health outcomes. So it's expected that a woman who enjoys good oral health should see her dentist during her pregnancy at least once for preventive care. And it's just basic math. Gestation is 42 weeks. There are 3 trimesters that are 14 weeks apart. And if we believe in the old twice a year visit, and again, this would be for someone who is healthy, that one visit should fall somewhere during that 42-week gestational period. This was a Cigna survey in 2015, and Cigna, of course, is an insurance company, where they found that 75% or more pregnant women experienced an oral health problem. And this was a questionnaire survey. Women were questioned. They were between the age of 21 and 45. 801 total women participated, so a fairly large survey. And 200 of these women were pregnant and had dental insurance, 200 pregnant without dental insurance, 201 that had recently delivered with dental insurance, and then the remainder without dental insurance. And the results of their survey, 76% of pregnant women reported having an oral health problem during their pregnancy or shortly after. 33% had bleeding gums, which shouldn't surprise many of us. 22% toothache, 27% increased tooth sensitivity, but 57% actually visited a dentist during their pregnancy. So almost half of these women surveyed did not visit the dentist during pregnancy, although they stated dental problems, right? Cost, of course, was one of the reasons cited. And again, this was a Cigna survey, insurance company. Women without insurance were twice as likely as those without insurance to not visit the dentist during pregnancy. So women who weren't insured, who were pregnant in this survey, probably weren't going to the dentist, at least twice as many as women who were insured. And healthcare professionals have the position to reduce the statistic by messaging to women of childbearing years about the importance of dental visits. And we know that many of our women of childbearing years are not messaged about the importance of their oral health as part of their reproductive health. All right, so this was an expert panel. Prenatal consensus statement announced evidence-based guidelines for oral health during pregnancy and early childhood. And this was in the California Dental Association as far back as 2010, and it still holds today, and that's why I've kept it in the presentation. And their statement was as follows: prevention, diagnosis, and treatment of oral diseases, including needed dental radiographs, the use of local anesthesia are highly beneficial and can be undertaken during pregnancy with no additional fetal or maternal risk when compared to the risk of doing nothing. And good oral health and control of oral disease protects a woman's health and quality of life. It has the potential to reduce the transmission of pathogenic bacteria from mothers to their children. And this is the maternal oral health triad. And when we look at the triad, it is made up of what? The prenatal, postnatal, and then perinatal. So prenatal is prior to conception. Perinatal is 3 months prior to 1 month post delivery, and then postnatal would be considered anything 1 month following pregnancy. And I say that sometimes postnatal is also between pregnancies. You know, when women of childbearing years oftentimes have multiple births. So again, it's really important that we look at this time period, women of childbearing years, as a continuum. So the ideal time, this is my quote, to prevent early childhood caries is in utero. It's prior to birth. So if we can message to these women while they are of childbearing years the importance of their oral health, there's a very good likelihood that we could help reduce the incidence of early childhood caries, because of the fact that much of this bacteria that is formed and untreated dental decay and untreated periodontal disease and so forth leads not to just adverse pregnancy outcomes, but it can also be transmitted to the child, right? So if we can treat these women, and we have a window of opportunity to do that and reduce the caries level and the bacteria level, there is a very great possibility that we could reduce a lot of the problems that their children may experience. And I happen to be an adult product of that myself. So if you're a boomer like me, many of our parents did not have access to the technology that we have today. And so we, unfortunately, are the byproduct of that. So that is very good for you all that are just graduating from dental school, because you have an entire population out there that could really use you. Okay, so oftentimes at the most critical stage of organogenesis, which is the first trimester, the pregnant patient may be completely unaware that they're pregnant. In fact, they could be in your dental practice today and they could be pregnant next Tuesday. So if they're in your dental practice today and you see that they're in that window of childbearing years, use the time to message to them about how important their oral health is, how important it will be to this family that they will create down the line, right? And that really is a message that can hit home for a lot of women, because sometimes it's one thing for us to take care of ourselves, but when it comes to our children, that's a whole different level. We put oftentimes our children's health and that of our infants, who may be down the road, well above our own health. So it's really important that we message the importance of their health as well as their unborn child. So we should treat all women of childbearing years as potentially pregnant, just as we should with messaging to pregnant women about the use of tobacco, etc. And oral health care should be extended also to the entire family because of the vertical and lateral transmission of infection. And oral health should also be an extension of postpartum care to include all health care professionals on that team. We want to be able to reduce the bacterial load in the mother, improve nutritional status when needed, and oral hygiene instruction, right? All critical to preventing disease in the unborn child. So the takeaway message here is treat women of childbearing years as a continuum. Optimal oral health and dental treatment protects, promotes the women's health and quality of life before, during, and after pregnancy. Recommendations for perinatal oral health include oral health education, oral hygiene, diet counseling, fluoride treatment, professional oral health care, xylitol gum or xylitol mints, chlorhexidine gluconate rinse, educate the mother or caregiver on behaviors that directly pass saliva to the child, eliminate sharing eating utensils, cups, food, etc., counsel smoking mothers, and communicate with all healthcare providers involved with pregnancy management. So the significance of prenatal oral health is that we know that the overall health status of the mother prior to pregnancy, as we said, is critical to her overall health and pregnancy outcome. And we know that women, again, may be completely unaware they're pregnant during the first trimester, and that's a critical time. So again, take advantage of every window of opportunity with these women of childbearing years to provide this messaging as a cautionary tale. Now, smoking, alcohol, drug use, oral and medical health status influence overall health of the mother and therefore the fetus and child well before conception. And in some areas, unfortunately, we have pregnant women who smoke, who use alcohol, use drugs, and so forth. And my first extraction experience as a dental student was at San Francisco General Hospital, and they brought a pregnant woman into me by taxi who had an abscessed tooth, and I had to extract it, and she was about very close to delivering. She was had a drug problem and was in rehab, and that was the first penicillin injection I had to give in the gluteus maximus, which was an interesting experience. But I remember thinking to myself that we have to sometimes treat patients that may not be in our own circle, that we may not understand, and do the best we can and do the best for them. So it was an educational experience for me that I'll never forget. Encourage and promote oral health and overall health in the women, again, of childbearing age. And we'll talk about perinatal oral health right now. So definition of perinatal, again, is 3 months prior to 1 month following birth, and we consider lactation as an extension of the perinatal time. And these are several citations that we have put together, and I've included a fairly new citation in your handout on, and we'll get to that part, treating pregnant patients and what the implications are for decreasing the possibility of low birth weight. Now, mother's oral health, again, during pregnancy is closely related to the oral health of her newborn. And again, we have citations here that support this for you, and you can take a look at those. Now, general health is important throughout life, particularly during pregnancy. And we know that pregnancy is characterized by physiological and psychological changes, some of which can adversely affect oral health. So let's talk about a few of those physiological changes. And I taught physiology at the college level. It's been a couple of years, but I find pregnancy and physiology pretty fascinating, what the body can do. So again, pregnancy causes profound changes in female physiology. So when we treatment plan, we should have a current understanding of maternal and fetal physiology. And we should have to determine that the benefits of providing the care during pregnancy far outweigh the potential risks. What are some of these physiologic changes? Cardiovascular, hematologic, respiratory, gastrointestinal, genitourinary, endocrine, orofacial. These changes include increased blood volume, concurrent anemia, and the hormones progesterone and relaxin, for instance, can cause increased laxity in preparation of childbirth. It relaxes the tendons and so forth. Because of the birth canal, we'll need to, of course, expand and stretch. So this can manifest as tooth mobility, and this is an example for you. A few years ago, I was in a public health clinic, and I was leading a study on refugees from El Salvador, and these were pregnant women. And these pregnant women were very, very young, between the ages of about 18 and maybe 23, 24. And many of them had tooth mobility between 2 and 3, right? 3, but not vertical mobility, but horizontal. And if you first looked at that and you saw the numbers, you'd be quite startled, and we were. So we had a pot of money, grant money, and money from a nonprofit to provide quadrant scaling and root planing for these women. Some of the bloodiest scaling and root planings you've ever seen. Many of these women, it was like their first dental visit, right? But what we noted in some that got to us and weren't able to get into the program right away, the majority of them, the mobility returned back to normal, right? Why? Because much of this had to do with hormonal and relaxing again. And it could have been that there were genetic factors involved and just in that patient population. All right, so cardiovascular. Hi, Dr. Gertzberg. We're going to get to Lido in a little bit here. Okay, so cardiovascular here, there's increased uterine mass. That compresses the inferior vena cava, and that can lead to venous stasis and increased risk for deep venous thrombosis. There are physiologic changes on the electrocardiogram, and physiologic heart murmur can develop as well. Now, we know that in pregnant women, we will see significant change in blood volume, cardiac output, and changes in systemic vascular resistance. We'll see a decrease in blood pressure, and we'll talk about the supine hypotensive syndrome here in a little bit. But around the 4th month, the volume of plasma increases in the pregnant woman. If you've been pregnant, some of you know around the 4th month, with both my pregnancies, I fainted in the 4th month, and it had to do with this. And this causes what? It causes a dilution of the red blood cells. So you've got a 40 to 50% volume of plasma that increases. So increased volume, all those red blood cells become diluted, and the body makes up for that by increasing the mass of the red blood cells by 20 to 30%. So what does that do? It creates a need for increased iron and folic acid intake. So I was pretty anemic. Now, cardiac output also increases 30 to 50% during pregnancy, secondary to a 20 to 30% increase in heart rate and a 20 to 50% increase in stroke volume. And these changes cause a functional heart murmur and tachycardia in about 90% of pregnant women, which disappears shortly after they deliver that infant and placenta. Now, hematologic, this can cause what can be caused is a hypercoagulable state that increases a risk for thrombosis, embolism, leukocytosis, and again, physiologic anemia that we just described a moment ago, and also generalized immunosuppression. The body needs to recognize that the fetus is not foreign, that it's supposed to be there. All right, respiratory. Respiratory, we see many women who develop sinus rhinitis due to increased mucosal fragility, increased risk of airway edema. And when we lay the patient back in the supine position, we can see decreased PaO2, right? That can increase the risk of hypoxia, as we'll talk about, decreased functional residual capacity and progesterone-induced hyperventilation. So we'll talk about the fact that we don't want to lay a pregnant woman flat on her back in the dental chair as we do most of our other patients. Question from Laura, and I think she's talking about the El Salvadoran. Do you think it was part of poor nutrition with these women? No, I don't. I think actually many of them were fairly well nourished. I think it had to do with laxity from relaxing. Yeah, so, I didn't notice any issues with poor nutrition, and they certainly didn't describe it. I think it had to do, it was multifactorial, and it's a good question. Okay, gastrointestinal. Because of relaxin and progesterone, you can see loss of lower esophageal sphincter tone. And this leads to increased risk of reflux disease, indigestion, also decreased gastric motility and increased intragastric pressure. Genitourinary, there is a loss of intravascular protein, and this causes decreased osmotic pressure. That leads to peripheral edema. So if you see pregnant women, usually in their third trimester, they might be kind of puffy hands, can't wear their rings anymore, puffy ankles, puffy face. That's what you're looking at usually. Increased glomerular filtration rate, which means they may clear drugs a little bit more quickly, and they need to use the restroom a lot, right? Also, urinary stasis, that can lead to an increased risk of urinary tract infections. And endocrine, we see an increase in estrogen, progesterone, thyroxine, steroids, insulin, an increase in the circulating 1,25-dihydroxycholecalciferol, and that is involved in what? The production of vitamin D. Okay, supine hypotensive syndrome, what is that? During the second and third trimesters, there's a decrease in blood pressure, as we said, and cardiac output when the patient is in a supine or laying completely flat in the dental chair. So it's due to decreased venous return to the heart from the compression of the inferior vena cava because of the uterus, the enlarged uterus. That can result in a 14% reduction in cardiac output. And hypotension, bradycardia, syncope, all are characteristic of supine hypotension syndrome. So the resulting decrease in stroke volume stimulates baroreceptors as a normal compensatory mechanism to help maintain cardiac output. And that is what leads to hypotension. The patient may describe nausea, dizziness, and even faint. So how do we prevent supine hypotensive syndrome? We have the pregnant woman elevate her right hip 10 to 12 centimeters by putting a towel or a pillow underneath that hip to relieve pressure on the inferior vena cava, and tilt her to the left side, okay? If hypotension is still not relieved, sometimes they have to lay full left lateral all the way, which makes treating that patient a little interesting. Now, I will share with you, with my daughter, I was on bed rest for 20 weeks. And I had to lay on my left side all the way like that for 20 weeks before I delivered her. And it was because of this. So when we lay the patient on the left side, though, we also want to elevate their head a little bit in the case they have any GERD or regurgitation or become nauseated. We don't want them to aspirate any of that eminence. Okay, respiratory here changes are due to what? This enlarged uterus and the increased maternal fetal oxygen requirements. So the diaphragm can be displaced because this uterus is taking up space in this closed container, so to speak. And this can increase intrathoracic pressure. It can increase chest circumference. It can cause a 15 to 20% reduction in functional residual capacity. So that's the amount of gas that stays in the lungs at resting expiratory level or at the end of a normal expiration. And in the first trimester, hyperventilation begins and may increase by 42% in late pregnancy. Now, shortness of breath or dyspnea is a common complaint of pregnant women second to third trimester. So we again reiterate here that because pregnant patients can develop moderate hypoxemia, meaning not getting enough oxygen, it's not a good idea to lay them in the supine position. Upper airway changes, we said that the upper airway mucosa can be more friable and edematous. This has to do with increased estrogen levels. And up to a third of women will experience severe rhinitis, causing frequent nosebleeds and upper respiratory tract infections. And if you follow pop music, Cardi B has severe pregnancy rhinitis and had to stop singing for a while. I just happened to see that in the news. Now, What does that mean for all of us? Well, hopefully you're using rubber dams. If you've ever had a rubber dam used on you when you can't breathe through your nose, it's not comfortable at all, right? Or if that patient requires nitrous oxide, and we'll talk about nitrous oxide in pregnant women, nitrous oxide doesn't work very well if you can't breathe through your nose. Okay, circulatory, there's an increase in the number of erythrocytes, leukocytes, and sometimes an increase in ESR, erythrocyte sedimentation rate. There's an increased rise in red blood cell mass. Again, we said physiologic anemia. Increased clotting factors 7 through 10, and decreased clotting factors 11 and 13. Okay. Gastrointestinal changes. I think this is one of the most famous ones of pregnancy, right? Morning sickness. Morning sickness is not just isolated to the morning. For some women, it can be all day. For some women, it can be all day up to 4 months. For some women, it can be all day, all 9 months. And some women have no morning sickness whatsoever. With my son, I had no morning sickness. I was 19 years of age, teenage mother. Here I am today. And I had no morning sickness. I didn't even know I was pregnant, right? I was married at the time, and we were on our way to Hawaii. We had no idea. Now, with my daughter, though, 10 years later, there was no question that I was pregnant, and I had comparative vertebrae anatomy at Cal. At 8 in the morning was the lab and dissections, and I would show up with rice crackers, and I couldn't make it through the lab. So I had to take my specimens home with me and put them in a freezer, because I knew between 5 and 6 every evening, I would be able to do it, because that was my window for feeling better. And at 4 months, it all went away. So I was lucky, but not all women are like that, right? So what you want to do, and I point that out, is ask this woman, because she's going to know, when do you feel better during the day? And she's going to say it's going to be from 2:45 to 4 o'clock in the afternoon. That might be when she has to be treated. You certainly don't want to appoint her when she has morning sickness. Makes no sense. Morning sickness is from estrogen and progesterone by and large. And but also women do have significant reflux sometimes, and we spoke about the sphincter, gastroesophageal sphincter as well, lower, because it becomes relaxed from the hormones, and there's a slower gastric empty rate. Hepatic liver dysfunction can also occur, and this can predispose a pregnant woman to preeclampsia. Preeclampsia is characterized by hypertension, proteinuria, and edema. And pregnant women that are identified with elevated blood pressure in your practice should be referred to their obstetric team for further evaluation, because it could signify hypertension. Patients with morning sickness, again, should not be appointed in the morning or times that they know they are having nausea, and they are advised to avoid citrus drinks or fatty foods that may increase gastric upset. And patients should be seated in a semi-upright position, as I said earlier. We should also provide them with specific oral hygiene instructions. So if they are experiencing quite a bit of vomiting, they should rinse with baking soda solution to neutralize the acid. But it's thought that they should not brush their teeth for 1 hour after vomiting. Instead, rinse with solution, a teaspoon of baking soda and 8 ounces of warm water. We talk about this a little bit later to try to neutralize the acids. Okay, endocrine changes here. Endocrine changes can occur with thyroxine, steroids, insulin levels, and also human gonadotrophin, which is a growth hormone. These are produced by the placenta, everything but thyroxine. And think of the placenta as a temporary gland, which is what it is. It's a temporary gland. It serves many purposes, but it also produces its own hormones. And gestational diabetes is something that you should be aware of, because 45% of pregnant women are unable to produce sufficient levels of insulin. So risk factors are positive family history of type 2 diabetes mellitus, obesity, ethnicity, and over the age of 25, I had gestational diabetes with my second child, and 20 weeks of bed rest. And I was checking my blood glucose 5 times a day. And I was on a 1,200 calorie a day diet there for a while. I had gained 100 pounds by the end of that pregnancy. I weighed 211 pounds when I delivered, and I'm 5'3". Okay, so what do we need to know about thyroid hormones? Well, thyroid or thyroxine, we see an increase. We know that the immune system, we said, is physiologically suppressed. And there are many women, not many, but statistically, women that can develop autoimmune thyroid disease after delivering their infants. And it's thought that there may be some connection. You may have heard of Hashimoto's thyroiditis, and that can occur after pregnancy, and it may be temporary or it may be for life. And that is when the body basically produces antibodies that attack the thyroid gland. Okay, any questions or comments? Sharon wants to know, did I have a hard delivery because I gained so much weight? Yes. I had a hard delivery because I had gestational diabetes. So my daughter was complicated birth. But she was born full term, so that was a good thing. And now she's a nurse, so I've contributed to the workforce. Oral and facial changes here. Let's go ahead and talk about those. Gingivitis, gingival hyperplasia, pyogenic granuloma, salivary changes that are caused by increased estrogen levels. So hypersalivation can occur. If you are using a rubber dam, you will have to suction behind that rubber dam a lot. Why? Because this woman is going to salivate like crazy. And when you take that rubber dam off, the saliva is going to be running down her chin and everything. So just be prepared that that's the case, or you'll be using a lot of cotton rolls and dry angles. So Richard, it can be either. Yes, it can be either. So some women that don't produce enough insulin, that can be gestational diabetes, or they're producing it, but it's just not doing what it's supposed to do, right? That's the problem. So it can be a receptor issue as well. Okay. Oral and facial changes here, gingivitis, as we said, known as pregnancy gingivitis or gestational gingivitis. It's caused by hormones and increased angiogenesis. So you'll have more blood vessels when you normally wouldn't, and extra bleeding. But as we'll see, oftentimes these cases of pregnancy gingivitis or gestational gingivitis may actually be periodontal disease. So I'll talk to you about that in just a minute. John said, "Wow, I'm glad I'm glad I'm a man. Pregnancy isn't for wimps." No, it's not. But Aubrey said no, Perio. That's good. Yep. So gingival pregnancy gingivitis definitely exists. So pregnancy, though, can worsen existing periodontal disease as well. It can, as we said, cause teeth to become mobile. And pyogenic granuloma is called pregnancy tumor. It's due to angiogenesis, increased angiogenesis. So I would sort of liken it to a sand in an oyster, and it's sort of an irritant, and it causes this pearl, right? In the case of a pregnancy tumor, oftentimes there is some irritant that stimulates this prolific tissue to grow. So it might be calculus or plaque that's left. And usually what will happen is that that pregnancy tumor, if you remove it during the pregnancy, it's just going to come back. So if it was around a muscle attachment or somewhere where it was really cosmetically an issue, or if it was one of the patients I was talking about that we were doing quadrant scaling root plane, if they were numb, I would remove it with a curette if I was there, because I'm going to go ahead and remove probably quite a bit of calculus at the same time. We know that increased salivary estrogen can lead to a favorable environment for bacterial growth, increased dental caries, periodontal inflammation, periodontal disease. We also know there are hormonal mediated inflammatory oral changes, and the mask of pregnancy is melasma, right, which usually fades after pregnancy, but can also be seen with the use of various hormonal drugs, including birth control. Let's see if there's anything I forgot here. I don't think so. I have to take a little sip of tea. It's not COVID anymore, but it's COVID reactive airway, and it just comes back every so often when my throat gets dry. Any questions or comments? Do you recommend a maintenance regimen for chlorhexidine rinse? I'll get to that in a minute, Jenny, because I'm not really a big fan of chlorhexidine gluconate, but I've seen it do terrific things in this patient population. How long after pregnancy, how long after delivery can you expect pregnancy gingivitis to resolve? That's on a case-by-case basis. It has to do with oral hygiene. It has to do with genetics. It has to do with how long it takes for their hormones to become balanced, and also how well they were managing their oral care before. All right, good questions. So pharmacologic effects during pregnancy, very quickly. Drug clearance is greater during pregnancy. Higher volume of drug distribution, lower maximum plasma concentration, lower plasma half-life, higher lipid solubility. And we know that drugs can have deleterious consequences during pregnancy that include miscarriage, teratogenicity, and low birth weight. Lactation also is a challenge because medications can be excreted in the breast milk, and it would be a toxicity that's dependent upon what the chemicals, the dose, frequency, duration, and the amount or volume of breast milk consumed. So we want to minimize pharmacologic risk. We know that there are a very small number of drugs that are teratogenic, meaning causing birth defects. In medicine, many more antibiotics are used and other medications relative to dentistry. We really prescribe a window of antibiotics and a window of therapeutic agents relative to medicine. So our job is not as difficult as medicine, I don't think. But we need to know the safety aspects of commonly used and prescribed medications. Now, several categories to be known to be teratogenic would be alcohol, tobacco, which we don't use in dentistry anymore, cocaine, which we don't use in dentistry anymore, thalidomide, which was prescribed in the 50s for morning sickness, and it led to horrible, horrible birth defects. Methylmercury, anticonvulsants, warfarin, angiotensin-converting enzyme inhibitors, retinoids, and some microbials. And this is the FDA 5 classifications, category A, B, C, and D, and then X. So category A were drugs studied in humans, and evidence supports their safe use. Category B, no evidence of risk to humans, generally considered safe during pregnancy. Category C, drugs that should be used with caution. Category D, drugs not to be used during pregnancy, like tetracycline or doxycycline. And category X, drugs not to ever be used during pregnancy. So antibiotics, most antibiotics cross the placenta. The macrolides, category B, may slightly cross the placenta, but they do not cause fetal anomalies, but we do want to avoid erythromycin estolate because it's associated with increased risk of reversible subclinical hepatotoxicity in about 10% of pregnant women. So its use during pregnancy is not recommended. The tetracyclines category D, avoid in pregnant patients and children due to staining of dentition and long bone malformation. Metronidazole is category B, which is, we know, Flagyl, can be used cautiously during pregnancy for oral maxillofacial infections. Now, the mycins up here, macrolides, does not include clindamycin. Clindamycin is not a macrolide. However, clindamycin has been removed from the guidelines by the American Dental Association because of C. difficile. So if you are still prescribing clindamycin to your patients, especially those that are penallergic, you should stop today. Take a look at our website. Take Dr. Palmeyer's course on antibiotic prophylaxis. It's a 3.5-hour course. He's the co-author of the ADA's guidelines. And I speak from experience. I had C. diff that followed clindamycin, and I had many, many recurrent infections and ended up in the hospital. So if you're still prescribing clindamycin, stop yesterday. And there it is. All right. So if you take his course, it's going to tell you what you can prescribe. It's not black and white, depends on your patient. So this is the box warning for C. difficile. Right? Why did the ADA remove it? Because dentists were getting sued and people were dying or getting very sick like me. Okay, so we've got some resources on our website here for you. So again, if you're still prescribing clindamycin and you're not up to date, there's the link for you to take Dr. Palmeyer's course. And also Dr. Goff. So her course is 1.5 hours, and she worked with Dr. Palmeyer. And she's at The Ohio State, clinical pharmacist, international expert on antibiotics and other antimicrobials. She was just lecturing in Western Pennsylvania, and I have, she sends me photos of everywhere she is presenting. And so she's spreading the word about my story and clindamycin to all dentists. And then we have the C. diff toolkit here, also sponsored by Perio Protect. And Perio Protect also has sponsored both Dr. Goff and Dr. Palmeyer's courses. So I do want to give them a shout of appreciation. We've got other CE webinars relevant to antimicrobials here. So please take advantage of that, not just for your pregnant patients, but all of your patients. All right, analgesics. What should you prescribe for the pregnant patient? Acetaminophen is best. Why? Less gastric upset, but there is a slight hepatic risk, category B. Aspirin can cause gastric upset, can also cause hemorrhaging, especially if it's close to the delivery date. NSAIDs, risk of cardiac septal defects, not advised in the first and third trimester, with limited use 48 to 72 hours maximum on a rare basis. And then COX-2 inhibitors avoid late in pregnancy because of ductus arteriosus, premature closure. Sharon wants to know, is that just for stopping for pregnancy? For clindamycin, clindamycin should be stopped for all patients. Yep, all patients. If you are still prescribing clindamycin, you need to stop because you're not within the guidelines, and it was removed by the American Dental Association in concert with the American Heart Association and the orthopedic surgeons because of the risk of C. difficile, which is great, much greater with clindamycin, but really any antibiotic can cause C. difficile. So there are pregnant women, about 1 in 100, when they deliver by C-section, they develop an antimicrobial resistant infection because all C-section women are given antibiotics before they make that incision. And they will develop C. diff. So it's very, very concerning, and it's a very serious infection. So if you don't know about C. difficile, take our course. All right, local anesthetics. We had Dr. Gertzberg ask a significant question here. There is no evidence to suggest dental treatment and the use of local anesthetic causes adverse pregnancy outcomes. This was a study in the Journal of the American Dental Association where they showed and reinforced that the use of local anesthetics and dental treatment during pregnancy not posing a major teratogenic risk. So there's no reason to prevent or delay dental treatment and the use of local anesthetics. So what about clindamycin gel for dermatological use? Causes C. diff. There's a risk. Yep. Cataract surgery. Levaquin eye drops for cataract surgery. C. diff. Because they can be absorbed into the system and it affects the gut microbes. And I would give a shout out to Deborah Buchanan. Always makes sure that she says hello to us on Facebook. I appreciate that. Can questions be delayed until the end of the presentation? Some of them, this is live interactive and we're required to answer the questions. All right, Sharon wants to know, what about patients that are not female and allergic to penicillin? It doesn't matter. Any patient that is allergic to penicillin needs something other than clindamycin. Okay, so no issues with epinephrine. So sometimes your obstetric team is going to ask you to not use epinephrine. All right, it depends on the provider. So Dr. Gertzberg, that could be this patient. So what I'm going to tell you now is that you come up with a form and you send a note to the obstetric team. Hi, I'm Dr. Gertzberg. I'm treating your patient, Sally Manali or whatever, and we're going to provide this treatment. This is the medication that I usually use, 2% Lido with epi, blah, blah, blah. Do you have any further recommendations? And they're going to come back and tell you if they want you to use epinephrine or not. Now, if you need to perform surgery extractions, let them know. And there's no harm in picking up the phone and actually calling them and talking to them on the phone, because physicians don't always understand the dental world either, right? All right, so nitrous oxide is safe in pregnant women when local anesthesia is inadequate, maximum level of 30%, decreased levels required during pregnancy. Again, use a rubber dam and make sure they can breathe through their nose. If you are an employee, that is different. Occupational exposure is a problem for you dental assistants and hygienists and you female dentists. What can you do? Go to the ADA's website and get a nitrous oxide badge. Wear a badge and know what your levels are, because the scavenging devices in dental offices are sometimes adequate, and it might be an older office, sometimes not great. And there's nowhere in that practice that's monitoring the levels for you. You can't go to some sort of device and see. So get yourself a badge. All right, these are guidelines for drugs used during lactation and pregnancy. And we spoke about analgesics. Acetaminophen is best. Again, you don't practice in a silo, so send over a transcript or whatever, dictate something, have it sent to your obstetric team for that patient, and let them know what your plans are, what your diagnosis is, and what the prognosis is, and the long-term plans. All right. Antimicrobials, again, you want to prescribe everything except erythromycin in the Estelit form. Stay away from the tetracyclines. So that includes doxycycline, tetracycline. Take clindamycin out of your formulary. Metronidazole should be used cautiously, as well as the antifungals. All right, this is a nice graph for you that breaks down what you can use and what you can't use by semester, and what you can treat and what you can't treat. And basically, I'm going to tell you that your guidelines here in the first, second, and third really don't change much in terms of procedures that you're going to perform. If your patient has a periodontal infection, it has to be treated no matter where they are in the spectrum of pregnancy, right? So, and then it also breaks down, again, the anesthetics, the antimicrobials, the analgesics for you as well. We spoke about teratogens here and comparison of common complications. Again, these complications, there's no evidence that supports dental procedures lead to miscarriage relative to miscarriages as a natural phenomenon, if you will. Okay, preeclampsia we spoke about. Challenging, does not contraindicate dental care. Periodontal disease, there's controversy surrounding the link of periodontal disease as a causative factor in preterm labor and low birth weight babies. What I will tell you is that the reverse also is, if you treat the periodontal disease, is it going to reduce pregnancy outcomes? And there is a document in your handouts that I included here that shows that the studies that support that were small studies, they're single center studies. The large studies, one Lopez et al., which is about 1,700 patients, didn't support it. They treated the periodontal disease in the pregnant women, and the pregnant women had the same number of adverse oral health or adverse pregnancy outcomes, low birth weight. So their question was, were we performing it at the right time, or were we a day late and $1 short, basically, right? So it all gets down to, again, oral health promotion, identifying the patients early on and messaging to them early on. We're going to supine hypotensive syndrome. There's a review here for you and a nice diagram of what that looks like. So we want to start with a comprehensive exam and treatment plan for every one of your patients, not just if they're pregnant or otherwise. So we don't want to cherry pick treatment from that comprehensive plan. If they haven't had an FMX in 10 years and you decide to take 4 bite wings and 2 PAs because you're worried about the radiation, you may miss something that could be more of a liability, right? And more of a problem for your patient. So OHI, preventive treatment strategies to reduce inflammation. Here are the recommendations. Again, I'm not a fan of chlorhexidine mouth rinses. I think we have better products on the market, but I've seen results with chlorhexidine. And my problem was in a public health department, the amount of staining and calculus that the patients would come back in, because they're not coming in every couple of months, right? We may not see them for a few months. So radiographs during pregnancy, again, there is no contraindication in taking radiographs, but they should be aproned and a thyroid collar. You can provide dental care during any trimester, but again, you have to have a conversation with the team and with the patient. If you're withholding care and you're telling them to come back and you've taken 4 bite wings and they have an abscess number 30 that you didn't identify and they end up getting ill and they're in the hospital and they're pregnant, that's not going to be a good strategy for you. So again, comprehensive treatment plan is indicated if it's required. Lactation amalgam restorations, my feeling is you should be using rubber dam on pregnant patients anyways. And the FDA states they don't believe there's an issue. I don't believe that myself. I believe we have to do everything we can to protect the patient. Teeth whitening, not indicated here. First trimester, second trimester, and third trimester recommendations are all the same. You basically can provide the care. However, and you should provide the oral hygiene, but keep in mind, the third trimester, your patient's going to be really uncomfortable. So if there's something that you didn't identify and they were in there for the first trimester and they come back with an abscess or they need a root canal, and now we're looking at root canal and your patient needs to go to the restroom every 5 minutes and they could go into labor any day, again, not a good strategy. Okay, periodontal disease, we said, is an issue, and adverse pregnancy outcomes linked to periodontal disease. We said here are some, quite a few studies for you. I'm going to scroll forward here as we close. So risk factors, periodontal disease can be exacerbated in your pregnant patient, and that has to do possibly with inflammation and cytokines, etc. Dental treatment in pregnant adolescents, just remember, pregnant adolescents are not miniature adults. So they require a different type of education and a different type of approach. Okay, genetics and periodontal disease, we have to consider pregnancy diabetes. So it's important, or gestational diabetes. Your patients that have gestational diabetes need follow-up afterwards. The gestational diabetes, the thought was that the placenta goes away and the patient is, boom, they're fine. But we know now that the placenta goes away and the patient is still at risk for developing diabetes long-term. It's interesting also to know that there can be more aggressive bacteria in pregnant women. And so in closing, what I wanted to tell you was at Maricopa County here, we developed a salivary testing program for all of the pregnant women that we evaluated. And what I saw were cases that I normally would have diagnosed as gingivitis, pregnancy gingivitis, ended up really being periodontal disease. So my thought is that we should be using salivary testing, especially in this patient population, because periodontal probes don't tell you about what those pathogens might be. It only tells you about loss of attachment, right? You might see some bleeding points. We really need to know what level of pathogens we're talking about. We also know that caries in the mother can lead to an increased risk of early childhood caries, periodontal disease linked to low birth weight and preterm delivery and stillbirth. This was a case of a mother who delivered a stillbirth infant, and she had had a cold. And they performed an autopsy and found that although she was diagnosed with pregnancy gingivitis, she actually carried fusiform nucleatum. She had an infection, a periodontal infection, which they found in the lungs of the infant and the placenta. Inflammation from perio disease is a risk factor for developing preeclampsia. So again, the goals of perinatal oral health care is to reduce the level of bacteria in the pregnant mother's mouth, to delay or prevent infection in her baby. And postnatal oral health, as we close, that is the medical school that I lived in for 4 years with my infant daughter in dental school. Postnatal oral health here. So I say that disease transmission among family members is a family affair. So the entire family needs to be screened, not just the pregnant mother, because there is lateral transmission of these pathogens between siblings and so forth as well. So use pregnancy as the teachable moment. And again, oral hygiene is required. Address morning sickness. I believe xylitol products are really important for patients, as well as fluoride, whatever your feeling and your patient is about fluoride. Diet, nutrition, address if they're having particular cravings. And then professional oral health care, always required for these women. If they're not able to chew gum, then xylitol mints are preferred too. All right, remind them also not to share salivary sharing activities. White spots, early childhood caries. So when you see those, there's a ton of bacteria there. These are all cases that I've treated. I didn't treat these cases, but similar to the cases that we've treated here at the county and other health departments I've been in. So this is what we're trying to prevent. All right, remember to communicate with your obstetric team, advocate oral health on behalf of the pregnant patient. Why are some dentists still telling women who are breastfeeding to pump and dump after receiving local anesthetic for dental treatment? So they're concerned about some of the local anesthetic crossing the placenta. Get the badge for nitrous oxide by going to the American Dental Association's website and doing a search. It's there. The second trimester is still the best time to treat the pregnant patient. The best time to treat your pregnant patient is when they need it. Alternative for mouthwashes. So I am a big fan of xylitol mouth rinses for pregnant women, xylitol mints. Radiation exposure is much less with digital sensors. So we have changed since I was a dental assistant in 1981. where it was a lot of radiation. So most definitely. And fluoride varnish. And Lindsay, thanks for bringing up. So I'm a public health dentist. I'm a big fan of fluoride varnish. So if you have a patient and you don't know when the heck they're going to be back in a clinic, I believe fluoride varnish is great because you may just have that one window of opportunity. At least it buys you a couple of months until they can get back in. All right. Any further questions, you can reach me through the website, and I'm going to bring up Dr. Tanya Dunlap's presentation here. I'd like to invite you all to stay here and hear from Tanya, and that is my presentation. Let me bring hers up. And let me go ahead and introduce Tanya here. And I am like bright red because it's 1,000,000 degrees in my office. It's like 85 here. It's 7 o'clock at night. Okay. I would like to introduce you all to Tanya Dunlap. She's the vice president at Perio Protect. She has worked since 2005, and she's responsible for the educational marketing and commercial programs at the company. Previously, she served as Perio Protect's research liaison, working with researchers and microbiologists testing Perio Protect in controlled clinical trials. And her expertise on this adjunctive periodontal therapy is grounded in the research data, explaining how the prescription trays work and which patient candidates can benefit from them. Welcome, Tanya. Thank you for being here. And I will be in the background here monitoring the chat for you.
Terrific. I appreciate that because the chat feature is going to be really important tonight. We're going to do something a little different. This is an experiment. I love Dental CE Academy audiences because you all are so interactive and we want your feedback. And we're going to discuss a few cases. So I did not know that stat that 45% of pregnancies had gestational diabetes. That was new for me. Some of the research that I have looked at, say 4 out of 10 pregnant women develop gum disease during pregnancy. And part of it is all of the things that Dr. Kroling talked about. And part of it just is that it's really hard to clean deep in a periodontal pocket between office visits. And I'm going to give you a short overview of what perio tray therapy from Perio Protect is. And then we're going to look at cases and I want your feedback. Like, what would you do? What do you think you would do in these cases? So the tray is just a simple yet really precise medicament carrier. I've got one here. I'm twisting it. It's really soft. It's flexible. It's comfortable. It has an internal peripheral seal, and the seal and the extension beyond it push medication deep into the periodontal pocket. The medication fights the infection. A primary antimicrobial is a hydrogen peroxide gel. It is very excellent. I'll just say it's a very nice alternative to antibiotics. It's an excellent broad spectrum antimicrobial. It works in distinct ways. Hydrogen peroxide breaks down protein chains. This is how it works as an antimicrobial agent. Your bacterial cell walls, a bunch of proteins linked together, it cuts through the protein chains, lyses the cell, and your cell dies. It does not kill all the bacteria in the periodontal pocket in one application. It kills the bacteria on the exposed surface layer that it comes into direct contact with. First, it has to cut through the matrix. The matrix is that like physical barrier of slime that has a lot of protein in it too. Once you get through the matrix, then it can kill the cells. It needs a minimum time point of 10 minutes. We really want patients to wear the trays for 15 minutes because the hydrogen peroxide is bubbling up inside the tray. This particular gel, which is Perio gel, or Perio gel X flavored with xylitol, has a slow linear rate of activation. What that means for you clinically is you're getting a slow, consistent release of oxygen. Now, 10 minutes is a good kill rate. You get 10 minutes of oxygen, but this gel continues to release oxygen for a full 17 minutes. Ideally, they'll go for 15 minutes. That oxygen's key. It changes the microenvironment. It puts your gram-negative obligate anaerobes on the defensive. It creates the right environment for healthy bacteria to repopulate. And when hydrogen peroxide gel is activating, releasing oxygen gas, increasing the volume pressure of oxygen inside a sealed tray. So the Perio tray from Perio Protect has an internal peripheral seal for every single tooth. That seal and the extension beyond it The blue stuff on this tray is just our logo, so you know it's the real Perio tray from Perio Protect. The seal and the extension beyond it work like a gasket. It prevents the medication and the oxygen from leaking out all over the mouth. As the volume pressure of oxygen increases inside the tray, you have the stimulation of new capillary beds. Then you have neovascularized tissue. It heals faster, it's stronger, and you see some gorgeous stippling in just a few weeks. So your primary protocol is to use the trays twice a day until your first tube of gel is gone. It takes about 3 weeks, and then you drop down to 1 time a day. And I'm going to show you 2 cases that are not related to pregnancy and 2 cases that are related to pregnancy. And I'd love to know what you all would do. So get ready to participate via the chat. So again, gingivitis, maintenance therapy, or let's say you've got lots of restorations, crowns, implant margins. You want to keep those margins clean. You want Perio Protect because it's important to treat an active infection. It is true that the tray delivery of hydrogen peroxide gives you the freshest breath of your life, even you all. If you want to try it, we have great professional rates. It also whitens teeth, not overnight whitening, but you don't also get the sensitivity. It's a low concentration. I didn't say the concentration. It's 1.7% hydrogen peroxide. 10% carbamide peroxide is the same as 3.4% hydrogen peroxide. This is half of that strength. It's very rare to have sensitivities. You will have whitening in a couple of weeks. Twice a day till your first tube of gel is gone, and then down to 1 time a day. Now, here's our first case. It's gingivitis. Here we have a 48-year-old woman. She's a non-smoker. She's taking Wellbutrin, 100% bleeding on probing. X-rays. It's gingivitis. Now you saw that 100% bleeding and probing. The picture gives you a little more information here. That is some serious bleeding, right? Now it's your turn. What would you do? 100% bleeding and probe. Let's explain these charts too, because Florida Probe has gorgeous graphics, which make it really easy to look at and understand quickly. The red diamonds are bleeding points. If it's a black vertical line, it's 1 to 3 millimeters. If it is a red or candy stripe, we don't see any candy stripes here, but if it's a red line, it's 4 to 5 millimeters. If it's candy striped, it's a lot deeper. So looking here, going through in the chat, let's see, I'm going to pull this up so I can see them more easily. What would you do? You could have the patient come in more frequently. What would you use? A rinse? What would you use? There are some great rinses on the market. 43, 46, scaling in the presence of inflammation. Yep, suggest an antimicrobial rinse. Aubrey, which antimicrobial rinse would you use? There are lots of good ones on the market. They have some molecular iodine rinses. They have some chlorine-based rinses. They have some essential oil rinses, all of which seem to have good data behind them. You can also prescribe Perio tray delivery of hydrogen peroxide gel. This is just a few months later. And you got down to 0 bleeding. You don't always get to 0, but you should get to single digits. And in gingivitis, it's pretty easy to get to 0. So just so you see, what the other nice thing about Florida Probe's VoiceWorks is that it gives you all of these gorgeous graphics. They are great results, aren't they? And then look at this. This is just from a couple months ago. So we're going into 4 years. So now we've got a couple 4 millimeter pockets, but we still don't have any bleeding. So Tracy says, scaling with moderate inflammation, then 2 weeks, prophy, fluoride with a microbial iodine rinse. Great. Paradox closest I like really, really well. Sharon, tray therapy is done at home. You use it 10 to 15 minutes at a time. Start out twice a day till the first tube of gel is gone. The reason you want twice a day is because every application kills more bacteria and adds oxygen. In those first 3 weeks, you're going to significantly decrease the bacterial load, and you change the environment so that healthy bacteria repopulate at the expense of the pathogens. Okay, gingivitis is a super easy protocol, and it's typically you get great results.
Hey, Tanya, I was going to mention too. So Wellbutrin Wellbutrin is, I think it was taken off the market for a brief period of time, but it's an SSRI, so it's going to cause xerostomia. It can
Yep.
cause some gingival hyperplasia. So, if you identify these patients on these SSRIs, it's to me a no-brainer. They should be just put on Perio Protect, just to prevent them from getting to this point, or at least managing it. So.
Right. It's important to treat an active infection, and it's important to prevent the progression of disease, right? So that's the other thing we really want to do. What grade mobility would you not record Perio Protect? Well, once you get past 2, you really need to stabilize those teeth. You can splint them together if you needed to, but when you get to lots of mobility, we're past. I mean, just let's be clear, Perio Protect is home care. It's not going to resolve serious deep vertical defects that still need surgery. But let's move on here for a moment, because these are great. How are the trays made? You send in a scan or an impression, and we'll turn them around for you in a couple days and FedEx them back to your office, and then you prescribe the medication. Hydrogen peroxide gel is almost always the case. All right, this is another kind of run-of-the-mill Perio Protect home care case, periodontal maintenance. So here's our patient. You can see the x-rays are coming from 2016 and 2017. I'm giving you a moment to check these out. And then here is our chart. We're going to say it's stage 2, grade A. You grade based on the progression of disease, which is hard to tell when they first come in for initial exam, nicotine usage, and also diabetes. He's pre-diabetic. He's not diabetic. He's not defined as diabetic yet. He does not smoke. He's a 39-year-old man. He is not a native English speaker, and he has really high dental anxieties. His bleeding on probing is 47% of the sites in his mouth. So what they did was scaling. They did full mouth scaling and maintenance every 3 months for a year. And they went from the 47% bleeding on probing with 107 sites greater to 3 millimeters in pre-treatment. And scaling matters, right? Scaling's good. You get good results. Let's look at the graph. The bleeding on probing went from 47% to 38% with scaling in combination with maintenance every 3 months. Okay, so now what would you do? What would you do after this? Your patient comes in every 3 months, and he's good. He's coming in every 3 months. He's trying. He did 1 round of scaling. You can use any scanner. I appreciate all these questions. You can use any scanner. Periprotect.com/connect is where you go to get all those instructions. I would love to know what you guys would. What do you do with the patient? They come in every 3 months. They've done scaling. It's been a year. Do you rescale them after that first year? Obviously, home care is an issue, right? You can't go home with the patients. We still have significantly deep pockets. All the striped vertical lines are deep pockets. The black line is 1 to 3 millimeters, quite a bit of bleeding still. 38% of the sites are bleeding. What they did was added perio tray therapy. Patient continues to come in every 3 months for maintenance. You can use Arestin, yes. In the deep pockets, you can totally use Arestin. I would recommend Arestin 1 round, and if it's not working for you, I would move on instead of using it every 3 months. You do need to have a pocket at least 5 millimeters deep, and so you can use Arestin. You just can't use Arestin and tray therapy at the same time. The tray will dislodge those minocycline spheres. So you can also refer to a gum specialist. Good idea. The use of hydrogen peroxide in these trays does not increase the risk of fungal infections, which would be like black hairy tongue, which is the question here, because the tray maintains the medication at the site where you want it. It's not washing all over the mouth. If you used a peroxide rinse, it is possible to have an overgrowth of yeast or other fungus, and that black hairy tongue would be evidence of that. So what you're seeing here is a 1 year of starting perio tray therapy in combination with maintenance. And in this case, they got down to 0 bleeding. You don't always get to 0, but you should get to single digits. All right, here we go. Third patient. She's in a new phase of her life. She is 25. She's thinking about marriage and a family. Her last dental visit was age 10. She's 25. I don't know if you're seeing more of this after the pandemic or not. She had a first round of SRP in 2021. She was not consistent with her maintenance appointments. Dr. Kovalenko, whose case this is, sent the patient off to the periodontist. She refused the specialist help. So let's look through and see. Here are her pre-treatment photos. It's been 15 years since she was at the dentist, right? Start thinking, what would you all do? 43, 46 is going to feature prominently, I suspect. But let's look at those x-rays. Well, those gums are super swollen and puffy, and there's lots of deposits. There's not significant bone loss. So when you use an AI analytic where we don't even get over 2.2, so, some of your PPO plans might even refuse scaling based on this analysis. So scaling was done. She was not good about going to her maintenance appointments. She refused the care of the specialist. This is what she looks like 6 months after the first round of scaling. So let's go back. This is pre-treatment. This is 6 months after the first scaling. A year later, she's got 100% bleeding on probing and mostly deep pockets. What do you do? One round of scaling a year ago, knowing she didn't go to maintenance, knowing she refused the specialist care. And yes, Rhoda, if you let me know where you are, I can help you figure out if we can do Perio Protect. Perio Protect's available in Canada. It's available in the Caribbean. It is available in some European countries. It's just the shipping is the difficult part here. What would you guys do here? We can do Jamaica. Thank you, Rhoda. A round of scaling, not good with maintenance, deep pockets throughout the mouth. I think that's 100% bleeding and probing. It sure looks like it. They did another round of scaling. This time they used Arrestin. So another round of scaling in Arrestin, and they get from 100% bleeding and probing to 68%. Then they start perio tray therapy. And in 2 weeks, the bleeding drops significantly down to, I think that's 18%. And by 9 months later, they're down at 2% bleeding on probing. That would be 3 bleeding points. We didn't get to 0, but we got to 3. And her tissue looks so much better. She's in a better position to be thinking about having that family. All right, and my final case, I really appreciate you guys participating. My final case is pregnancy-induced adult onset type 1 diabetic. I will preview this by telling you the baby was born healthy, mama was left with diabetes. So here we go. And this is a real world situation. She's 33. She's allergic to insulin, which in this case means she's got some just discomfort, swollen skin at the site of the infection, at the site of the injection. She had ortho in 2006. She has a maxillary Hawley retainer, lower slipcover retainer. Her A1C is totally out of control. If you are diabetic, it should be 7 or less. 12 is out of control. 97% of her sites have bleeding on probing. 75% of her pocket depths are greater than 3 millimeters. And then here's the rub, right? She has no dental insurance and she declined the in-office credit plan. She's going to have to save for scaling. Let's look at her x-rays. We've got some areas with some pretty severe bone loss. So home care is an issue, right? It is. It's a big issue and we need it. And just for the sake of time, I'd love to hear your thoughts, what you would do with this, but you're really kind of up against a wall with a patient who has to save for scaling. And perhaps she's scared of it also. I know. So an insulin allergy, it's rare, right? You figure your body produces insulin. It should be natural, but 1 to 2% of patients with diabetes have an allergy to insulin. It's not, uh, Dr. Baird, you might try Perio Protect. Let's try it. I'm going to show you what they do. They did a full mouth debridement and irrigation. They use chlorhexidine, a fluoride varnish, put her on doxycycline. Now, Dr. Rowling may come back in here and let's have that conversation about doxycycline. They did that first while Perio trays were being made. The trays were delivered on November 21st. So what you are seeing here is December 12th. This is the debridement, the irrigation, the doxycycline, and Perio tray therapy for about a month. Her bleeding unprobing went from 97% to 29. They repeated full mouth irrigation, a little more debridement at this office visit, scheduled root debridement therapy for March 12th. On April 4th, March 12th, they did teeth 6 through 11. Patient was still trying to work all out the finances. 23% bleeding unprobing at this appointment. Did the remaining root debridement therapy on April 18th. So a couple weeks later, and what you're looking at here, July 11th. Now her bleeding popped up a bit. Her pocket depths are so much better. But what's exciting is the A1C at 7. This is truly, really important service for your patients. So as a summary, you can see tremendous reduction in bleeding unprobing, big drops in pocket probing depth. So originally 75% of the pockets were greater than 3 millimeters, and at the end we're down. We get back to 19 there in July. What's exciting for me is that you are able to really help a variety of patients here. Dr. Rowling, do you want to talk about the doxycycline usage?
Yeah, we mentioned it earlier too, that doxycycline is not recommended now in pregnant women for the same reason that tetracycline is, but it can affect long bone growth and so forth. So, but again, you don't practice in a silo, so maybe they had some reason. And 100 milligrams, I'm wondering back then if that was the Periostat. Remember when we used to prescribe that low dose?
Right.
Yeah.
I think it was Periostat. I was trying to look that up earlier today. So it's hard when you want to go straight into scaling, right? Or Perio trays first with scaling. I do want to show this photo. Look what happens when you treat with hydrogen peroxide and you have lots of calculus. So calculus is basically a skeleton of protein. Hydrogen peroxide denatures it, makes it really goopy and soupy, easy to remove, which is great for the hygienist doing the procedure. It's a lot less time, lot less work for your body, and also, of course, easier for the patient. We do, if you want information, I see a couple of people saying, we want more information. Tap here at the top, the blue, reach out. There's information there where we are happy to train offices. I'm going to put up my contact information for you also. Please send your questions in. It is clearly true that people need to brush and floss, but I don't know how that's working for you. You can tell people to floss till you're blue in the face. One of my favorite dentists says 9% of Americans say they floss, and I think half of them are lying. Most people who come to the dental office brush their teeth, but let's go back, right, to the very premise. Toothbrush, rinse, and floss just cannot get deep enough once your pockets are 3 millimeters or deeper. You get that bacterial infection, you get the inflammatory response, and you really need additional help between office visits. And that is what the Perio tray therapy is designed to do, to gently deliver that medication, change the microenvironment so that healthy bacteria repopulate. Thank you so much, everyone.
Sorry, Tanya, I didn't mean to talk over you. There's a banner at the top of the screen, everyone. So if you want to reach out directly to Perio Protect, you can tap on the Tap Here button, and it'll take you to the landing page and the information if you want to set up a meeting with them or talk to Tanya. Just tap on that button. Question or comment from Dr. Jorgensen: consider oral irrigation with dilute sodium hypochlorite.
Yes.
I have to say that my former periodontist had a pre-procedural rinse protocol with dilute sodium hypochlorite, and I explained to him if I had to continue that, I was going to lose my cookies in there. It was the worst experience ever.
From the taste?
It was horrible. It's like
Yeah,
the first time I went
yeah.
in there, can't we do something different than this, you know? And they were pouring it out of the plastic laundry jug into the thing in front of you. And I said, you know, if I was looking at just basic practice management, you know, the periodontist is not exactly the place you want to be anyways. No offense, but most of your patients are really high anxiety by the time they get there, and they're looking at you making a rinse out of bleach. And I was like, ah.
That molecular iodine rinse would be a good option. I really like the IO rinse.
The IO rinse is a good option, and
Yeah.
its efficacy is proven, and they're just rolling out a new product called Ultra with xylitol. So,
Oh, nice.
yep. So again, reach out to Tanya. Everyone does have this in their folder, this presentation as well. So you have Tanya's information. Thank you so much for being here tonight, Tanya. And you got through all these cases pretty darn quickly here. So
yeah, I appreciate this chance to be with you. Thanks so much.
Thank you. Take care. All right, everyone, we're going to go ahead and close. And again, reach out to Tanya and Perio Protect if you need to. Tomorrow, take this information back with you. You can also bookmark that link by tapping on it at the top of the screen and save it to your device. I'm going to close you all out now, and you'll be taken right to the quiz to complete. Shouldn't be an issue. I do want to remind everybody here too that Saturday is our 3-hour infection control course. So if you need infection control, go to the website. You'll see it this Saturday, and next Saturday I'll be presenting both of those classes. Otherwise, have a terrific week. We hope to have you join us again, and we thank you really very much for being here this evening. Here comes the quiz.